Okay, it's 3:01. Good afternoon. Welcome to NYMC's Department of Public Health National Public Health Week Speaker Series. I'm Dr. Mark Kittleson, Chair of the Department of Public Health. We have an exciting week scheduled, starting today with Dr. Howard Kipen's talk. We'll be introducing Dr. Kipen shortly. Other speakers this week will include Dr. Oscar Aline from the National Association of County and City Health Commissioners, our health officers, on Tuesday, Dr. Nancy Stambler, Progenics Pharmaceuticals, on Wednesday, and Dr. John Allegrante, Columbia University, on Thursday. First, a few items to deal with. This is being recorded and will be posted on the department's webpage within a short time. I'll be typing that website into the chat shortly. This event is also sponsored in part by the student organization STUI, Student Healthcare Executives, led by President Brian Batista. I thank Brian and all his officers for helping to make this event happen. STUI is very much involved in service to the community and to campus. And for more information, you can go to STUI's webpage, and I'll be posting that into the chat as well. We ask that you stay muted, and if you have a question, please type it into the chat box. At the end of this presentation, we're going to have between 10 to 15 minutes of Q&A. A representative from STUI will collect the questions and ask them of our speaker. We are also being assisted by the Department of Educational Media with Michael Frankfurter, serving as our IT specialist. Should there be any problems with this event, like a Zoom bombing, we will end the presentation and we will immediately send you an email with a new link. Thank you, Michael, for your assistance. Finally, we're also trying to comply with our accrediting agency's request to maintain contact with our alumni. If you are an alum of our MPH, an MS, or DRPH program, we ask that you consider completing our alumni survey. And I'm going to be posting those into the chat a little bit later on. We have one for the MPH and MS and the other for the DRPH. So with no further ado, I'd like to introduce our Dean of the School of Health Sciences and Practice, Dr. Robert Ambler. Dean Ambler will be introducing today's speaker. Dr. Ambler.
Thanks very much. Thank you for the privilege of kicking off this fantastic National Public Health Week agenda. And everybody, happy National Public Health Week. Let's all send cards to our friends and family and celebrate another year where public health, for better or for worse, has really been at the forefront of everybody's newscast, everybody's mind, and protection of everybody's family. I also appreciate the indulgence of two of my very best friends, Dr. Diane Heck, Dr. Jeffrey Laskin, who are great colleagues of our speaker this afternoon, who have allowed me to do the honor of introducing Dr. Howard Kipen. Howard Kipen is a graduate of Berkeley, UCSF, and Columbia, with an internal medicine residency at Columbia, at Columbia Presbyterian Medical Center here in New York, and an occupational environmental medicine fellowship at Mount Sinai, also in New York. That department that bears the names of some great people, including Dr. Selikoff from many years ago. Dr. Kipen is currently Professor of Environmental and Occupational Health at the Rutgers School of Public Health. He has been at Rutgers for over 30 years and has been a major factor in the Rutgers Environmental and Occupational Health Sciences Institute, which at CDC we always called EOSHI. And I have to say was always one of our best grantees. We gave a lot of grants to EOSHI, not just because we liked them and we liked their name, but Dr. Kipen and his colleagues always under-promised and over-delivered. And for the grant money that went out, he was exceptional in providing us with really useful, actionable information in a variety of areas. Now, he has authored over 180 scientific articles, book chapters, and reviews on topics in environmental and occupational health, many of them on the health effects of air pollutants, both indoor and outdoor. Since 2004, Dr. Kipen has directed human mechanistic biomarker and air pollution studies in Beijing, Chongqing, Reading, UK, and the US to understand how air pollutants affect cardiovascular and respiratory health. He is currently a principal investigator on an EPA study that is looking at climate change impacts on air pollution and the use of indoor air cleaners to reduce health risks. He also directs an NIH study on the use of portable air cleaners to reduce viral aerosol levels in the homes of newly infected patients. He served or chaired a number of committees at the National Academies of Medicine, National Academy of Sciences, NIH, the Department of Veterans Affairs, the American Thoracic Society, and Department of Defense. From 2009 to 2016, he chaired NASA's Standing Review Panel on advanced environmental health and food technology. Many people don't think about all the stuff going up there in space, but space in the capsules is very limited. And so this is a very, very delicate balance. He chaired the ATS Scientific Assembly on environmental, occupational, and population health from 2017 to 19. His current research focuses on how carbon dioxide might actually function as a neurotoxin and how burn pits may have injured US troops. Dr. Kipen has always been a great friend of our school, great friend of mine and my colleagues at the CDC, going back at this point truly for about 30 plus years. And it's just such a joy to have you here this afternoon, and welcome. We hope you'll always remember with pleasure your time with us this afternoon at New York Medical College. Ladies and gentlemen, Dr. Howard Kipen.
Oh, thank you very much, Rob. That was really overly generous. And, you know, I wish my mother could have been here to hear you. Thank you. Well, thank you all for inviting me to kick off National Public Health Week. I'm going to talk to you not about any one thing, but kind of run through a potpourri of how I think about air quality and kind of how I got to the point where I'm actually thinking about carbon dioxide, which is not supposed to be toxic, but will end up kind of around that. The main thrust of this is to think about outdoor ambient air and indoor air and how they're similar, how they're different, and how they both can affect our health. Well, that's it. Why won't this advance?
So Dr. Kipen, if you just click on your screen.
There it goes. Okay. So I have nothing to disclose. This is a picture of our Environmental and Occupational Health Sciences Institute that Dr. Amler loves to pronounce. And c'est la vie. This is what I'm going to try to talk to us about in the next 50 minutes or so. The epidemiology of outdoor air pollution, but you'll see that it's also indoor. How air pollution hurts us, which is kind of the major sub-theme here. In particular, I'm going to demonstrate that with a little time devoted to a natural experiment we did in China. Talk about some more controlled experiments that we've done in New Jersey. Address the issue of indoor air pollution epidemiology, of which there may or may not be very much. Talk about how there are some things we can actually do to beyond governmental regulation, which is what we'd always prefer, to deal with some of the pollution that's around. And then talk about carbon dioxide a bit, and finally air cleaners and viruses. So particle air pollution is what we talk about the most, although there are other so-called criteria pollutants that the US EPA regulates and the World Health Organization promulgates. But a particle air pollution is really anything liquid or solid that, including liquids, that's suspended in the air. It includes both combustion particles that we worry about a lot and geologic particles as well that we may be a little bit less worried about, but they all add up to when we measure PM 2.5 or PM 10, they all add together. There are also secondary particles that aren't emitted from anything but form through atmospheric chemistry. And in general, we talk about particles by their diameter, which we measure in microns. Maybe some of you who, in fact, I'm going to guess any of you who have ever studied air pollution at all have seen a slide that's somewhat similar to this with the human hair sitting here in the middle. And these little guys on top are what PM10 is, which is everything smaller than that. And then PM 2.5, which is where we think a lot of the action for heart and lung and other toxicities resides. Although these ultra fine particles here, which are less than 0.1 or PM 0.1, they are what are called, if they're man-made and engineered, we call them nanoparticles. And they pretty readily pass through the alveolar capillary barrier into the bloodstream and presumably can circulate to some extent from there. And we'll think about that more when we talk about cardiovascular outcomes from air pollution inhalation. But anyways, these ultrafine particles are the products of combustion, and they're not homogeneous like engineered nanoparticles are. These are the criteria pollutants that EPA regulates. Up at the top is our friend particulate matter, and then the gases, sulfur dioxide, carbon monoxide, nitrogen dioxide, ozone, and lead, which has pretty much been well dealt with by changing its, or by assuring it's not in our gasoline. And then there's 189 hazardous air pollutants, which can include such friends of public health as benzene, toluene, naphthalene, formaldehyde, and other things that may be associated with combustion in vehicles and various other sources, but they're not specifically regulated to a concentration either in mass or parts per billion, parts per million, like the gases, like the 6 criteria pollutants up here are. Just to give you an example of a common source of particles is diesel exhaust, which we see less and less of as buses move to cleaner but not clean fuels, or even to really clean fuels like electricity. But these particles come out of your combustion engine often as a mixture of gases and particles, and then they can condense within seconds as they sit in front of you and go through kind of an evolution from being gases to condensed gases to ultrafine particles to PM 2.5, and then getting on larger. You can see the particles themselves down here in the lower left, and then this schematic of the layers. And so in here you have a carbon core, which is relatively inert. You've got organic compounds out, secondary compounds like sulfates and nitrates and metals, and then finally your air toxics on the surface. So this is a diesel particle. Diesel particles are not that much different from other particles of combustion, although they do have some distinguishing characteristics. But we use diesel particles in our experiments a lot, not so much as diesel qua diesel, but we use them as a model of a way to generate particles and do some experiments, which I'll tell you about in a bit. Just to show you where ambient particle pollution, which is what we're talking about right now, is this here. And this is a disability adjusted life years from, I don't have an updated version. This is about 10 years ago, but it's not too different from what we see now, where the major causes of morbidity, are hypertension, tobacco, alcohol. And then we have household air pollution, but that's from people burning biomass, cow dung, wood, and other things, peat indoors. And then here's ambient particle air pollution, which we're going to talk about. And the burden of health outcomes from that is not largely respiratory, as you might think it is. The respiratory part is actually this little light blue part here. This is childhood neonatal morbid outcomes. This is the light blue is cardiovascular, which is the majority, and then a small amount for cancers up on the far right side, mostly lung cancer, which we're not going to talk about a lot today. This is an older slide. It's from the EPA itself when they were still measuring largely as PM10 rather than PM2.5, which is now the preferred measurement. And what it represents is the change in day-to-day deaths in a series of US cities, which you can see down here. And this is a death certificate study. So they're looking at total deaths, cardiovascular deaths from stroke, myocardial infarction, heart failure, and the like, and then respiratory deaths up here. And what you can see from looking at it is increasing from total deaths to cardiovascular to respiratory, we have increasing levels of risk or increasing percentages of change as in almost every single city. For some reason, Birmingham wasn't significant for respiratory. But what you can see is even though particle pollution kind of logically confers a greater risk of morbidity or mortality through a lung pathway, a respiratory pathway, what this slide doesn't show you is that big powder blue section on the last slide, which represented cardiovascular disease, it ends up being much more significant in terms of numbers of deaths because cardiovascular deaths are so much more common in developed societies than are respiratory deaths. Heart attacks are much more common than respiratory failure, especially since tobacco use among adults has gone down so much. So what also is interesting, in fact, really interesting, is that the risk that is conveyed by the particles happens both on an acute basis, meaning within hours to a few days from an exposure or an increase or a decrease in exposure. So there's that acute phenomenon, but there's also the decades-long chronic phenomenon. And so particle pollution and some of the gases like ozone have an effect on both the chronic development of cardiovascular morbidity and then the acute episode that lands you in the hospital or other places you don't want to be. So here's a cartoon showing you on here a nice clean cross section of a blood vessel. Here's a longitudinal section, nothing going on there. As you age and eat a Western diet, you start to form these little cholesterol accumulations in the wall of your arteries, coronary arteries or any other artery, but coronaries are popular. And you see the plaque gets larger and larger. There are infiltrations of inflammatory cells there, macrophages in particular. The plaque, as it's come to be known, it's encapsulated and it's pretty happy to be there like that. But when something comes along and disturbs that fibrous plaque, something perhaps like an ultrafine particle or some degree of oxidative stress that's mediated by by some process that we don't completely understand, where inflammation that was set up in the lung somehow spills over into the systemic circulation and travels along. But anyways, or just from its own internal inflammation, the plaque ruptures, and then you have this whole accumulation of a clot. Mostly what you see here is the red cells, but the clot would include, of course, platelets, red cells, white cells. The artery is here obstructed, and whereas here, it only became symptomatic when maybe you exerted yourself, and so you get angina because there'd be enough blood supply at rest to oxygenate your cardiac muscle. But when you exert yourself, not enough blood can get through this narrowed area. And so you'd have chest pain when you exert. That's considered angina or stable angina. But here, when the clot comes, the artery is completely obstructed, and in simplified terms, you have a coronary thrombosis, and nowadays you need to get that cleaned out rather quickly. Otherwise, in the good old days, you would have just died. So moving on a bit in our understanding of things, when particles here in the upper left come into your lung, there's a number of things that can happen that we think help to mediate the clinical outcome, like a heart attack or a stroke. Well, those are the two big things we worry about, or heart failure. So the particles can set up changes to your autonomic nervous system, which affects something called heart rate variability, which confers a risk for usually acute illness. They can set up oxidative stress and inflammation, as I was discussing, in the lung. That spills over into the vasculature. They can also cause, after they reach the systemic circulation, they can cause increased coagulability of the blood. And all of that leads to effects on the blood vessels, and then the clinical outcomes of vessel constriction, high blood pressure, endothelial dysfunction, which we think comes along with aging vessels that become atherosclerotic. They don't respond appropriately to hypoxia or other signals. You can get blood clots, as we just showed you in the heart, chronically atherosclerosis, and maybe something about the inflammation influencing the plaques towards rupturing. And then again, all these clinical outcomes down here in the red. So what we're going to talk, and then I'm going to give you another specific example of what we do. This is looking at, again, it's somewhat older data, so it's PM10, looking at what happens with heart failure, or the heart not pumping enough blood. It's not a heart attack, but it chronically doesn't pump enough blood. And this epidemiology study looked not at death certificates now, but it looked at hospital discharges from Medicare patients, almost 300,000 discharges, who were discharged with a diagnosis of CHF, which is congestive heart failure. We've kind of dropped the C from the nomenclature, so it's just HF now, or heart failure. And using what's called a case crossover design, which I won't describe for you, but it's very interesting, you can see that across all these cities, again, with Birmingham being somewhat of an outlier, the summary relative risk is up about between 0.5% and 1% increase for a standard change in PM10 levels, which again, like that prior one, was 10 micrograms per cubic meter. So for every increase of 10 micrograms, standardized to 10 micrograms, there's somewhere between 0.5% and 1% increase of being admitted to a hospital where your diagnosis was heart failure. And now we have a little more epidemiology for that. And this shows, again, this is really the same slide as before. And what this is showing you is just about most of that risk all happens on day 0, the same day the pollution changed its concentration. So this making somebody who already has heart failure get hospitalized for it is happening on the same day the pollution changes, because we don't have an increase if we go back 1 day or back 2 or back 3. So that's pretty interesting. That's telling us something acute happens. And that's just epidemiology. Nobody's touching any patients. They're just looking at vital records, if you will. So we got the idea a few years after that to see if we could find a biomarker of that. And it turns out there were a bunch of heart failure patients who had this Medtronic device implanted in their hearts. The catheters implanted. This metal piece here would sit under your skin. And this device measured the pressures in your heart, multiple times a minute. And it measured those pressures and then would transmit them to your doctor. Because when your heart failure is decompensating, so you might have to go to the hospital, it's usually because you have too much fluid or too little. It could be either one in your body. And the doctors have to know whether you should increase your fluids or they should give you more diuretics to take them away. So the idea that this device, by measuring the pressures, would help the doctors do that. Well, it helped the doctors to know what the pressures were, but the outcomes were, no, the patients didn't do any better. They didn't stay out of the hospital. They didn't live longer if they had this. So the device was never marketed. But we were able, through colleagues at Robert Wood Johnson Medical School, at the time Robert Wood Johnson Medical School, now it's Rutgers Robert Wood Johnson, we were able to get our hands on the data for 11 of the patients who had this device as part of safety and efficacy testing. And we got those data, we plotted them for the 11 patients in New Jersey based on the closest air pollution monitor from the network that's run by the DEP for the US EPA. And what you can see here is that when the air pollution increases by what's called an interquartile range, it turned out to be about 11 millimeters of mercury here. When the air, I'm sorry, about 11 micrograms per cubic meter of PM. Now we're measuring 2.5 because this is a newer study. When the air pollution increases by that much, on the same day that it happened, the right ventricular pressures, the right ventricular, which is the unfilled circle, and the black circle is an estimate of the pulmonary artery pressure. Those two both went up statistically significantly. And again, going back many days, the effect went away. It was only on that day. But we think this could either be the cause or the effect of a heart failure episode. And so we take this really as a biomarker, and that's the first time I've used this word, but a biomarker, which is not the clinical event. The clinical event itself is landing in the hospital. The clinical event from the cartoon I showed you before is having a heart attack. But this is a marker that shows that there is something that's a harbinger, if you will, or something on the pathway to lead you to the actual clinical event, which is what we're interested in understanding and preventing. The biomarker is just something that allows us to look inside and not necessarily have to wait until the bad thing happens. So I'm going to take you back now to, let's say 2006 it was about, where through my colleague, Jim Zhang, who was then at Rutgers, we got wind of the fact that the Olympics were going to be held in China, and the Chinese government, Beijing, promised the International Olympic Committee that they would make the air a lot cleaner than it normally was. And I don't think, yes. So anyways, we wanted to study what happened to healthy young, they were medical students with an average age about 25. We wanted to see what would happen to a lot of biomarkers in them of what we thought were, or what were hypothesized to be the mechanisms that eventually produced adverse cardiac and pulmonary outcomes. And so we measured biological markers that indicated inflammation in the blood, as we thought the particles might cause, indicated dysfunction of the blood vessels, which we think contributes to both getting atherosclerosis and to some of its complications. We were very interested in whether their blood would become stickier, if you will, more likely to thrombose. We did not, well, we looked at autonomic dysfunction, and then finally we looked at levels of oxidative stress, or an outcome of oxidative stress. And we hypothesized that during the period of the Olympics, when the air pollution was essentially turned off or turned down by the government, that these biological markers would get improved. And then after the Olympics, when they were going to go back to having their booming economy, that the biomarkers would get not so nice again. So here is summarizing what happened. These are pictures taken from the roof of the hospital where the students lived and worked in central Beijing. And you can see this is on a typical day from before the Olympics. And over on the right side is a more typical day during the Olympics. Now, it was far from this clean day to day. There's certainly a lot of variability there. But if you look at these next two slides, you'll see this is the concentration going from before the Olympic decreases in pollution. Well, they did a lot of different things to lower their pollution. And what you can see here with this as the zero, this vertical is the zero line, is that every type of pollution, PM 2.5, sulfur dioxide, carbon monoxide, oxides of nitrogen, skip the ozone for a minute, elemental carbon, organic carbon, they all went down, except ozone. Ozone actually went up, and we'll talk about that in a minute. But everything else improved in terms of the air pollution. Much of it significant, although not the PM 2.5. If we look at this next slide, this goes from during the Olympics when the pollution is low to after the Olympics when the pollution gets high again, because they turned off all these restrictions to cars and trucks and construction and power generation in the area. Everything got better. And again, PM 2.5, our favorite, is not significant, but it sure is better, in this case by about 30–40%. Well, you ask, so fine, so the air got cleaned up, but what did that mean to health? Well, there's some epidemiology from when they cleaned the air, and they found some things like stroke got a lot better, but it was very messy. And that's, of course, because even though the medical students stayed where they were, when you're looking at the whole population of Beijing, the Olympics, because they cut off so much transportation, nobody was really home. It was things were very mucked up in terms of doing a general epidemiology study. And so while there are some outcomes like neonatal outcomes that came through, a lot of stuff didn't show up very well in clinical epidemiologic studies. But here, and this is just a list of all the different biomarkers of inflammation, autonomic stress, endothelial function, platelet sticking. We used all these different little markers, which I'm not going to name for you, but I think the slides will be available. So we used all these different markers of the biomarkers of the pathways that we thought led ultimately to acute or chronic events. These markers here, EBC is exhaled breath condensate. It's basically the water vapor in your lungs. And FeNO is a gas. Those of you who take care of asthmatics will know that. And what you'll see, and MDA is a marker of oxidative stress, malondialdehyde, and finally pH, which goes down with inflammation in the lungs or goes up without inflammation. Everything there from the lungs got statistically significantly better. Lowered levels of the biomarkers. That's true for these clotting factors, von Willebrand factor. Fibrinogen didn't change. And then down here for platelet stickiness, my favorite markers, they got much better as well. Heart rate got a little better and blood pressure went down as well, but not so much. So everything got better except I left off the autonomic heart rate variability change here because it didn't change. pH moving the other way, that's better. If we look at what happened after the Olympics, we see the exact flip. Everything, all the markers went up again, and except pH. And in this case, markers going up is not a good thing. So we found that that when there was more pollution, and I should say that in general, they were trying to go down from an average about 100 micrograms per cubic meter down to 40 or 50 for PM 2.5. And they made it, but again, because of variability, it wasn't exactly significant. But nevertheless, we felt we demonstrated that respiratory inflammation, systemic blood inflammation, oxidative stress, platelet activation, all improved in these healthy young adults and then went south again after the Olympics. So the key for us here was not just that we validated the pathways and made more sense of the biomarkers, but that it was reversible. And maybe the atherosclerotic plaques, as we see we saw from Vietnam, that there were plenty of 18 to 20-year-old American kids who already had beginnings of atherosclerosis. But that at least the biomarkers as we could measure them got better again. And I didn't mention the ozone. I'll just say very quickly, ozone is a secondary pollutant that comes from volatile organics and nitrogen dioxide that are emitted from cars and react with sunlight to make ozone. It turns out that nitrogen dioxide and nitric oxides of nitrogen that are emitted from the cars, not only do they make ozone, but they actually titrate it down at the same time, or in a complex mixture. They lower ozone levels. So when you took all the trucks off the road, you still made some ozone. The atmosphere still made some ozone, but there was much less oxides of nitrogen to titrate it. And so that's what, because the trucks were really gone, and that's why the ozone actually rose when everything else got better, and it went down when the trucks came back, and it could be titrated down again. I know that doesn't make sense, but just remember there's often higher ozone levels in the suburbs than in the inner cities. So we were interested at EOSHI, me and Rob Lumbach and Jim Zhang, who was still there, to see if the things we had found in Beijing, the biomarkers, could be replicated in New Jersey. Now, I told you that in Beijing, the average PM 2.5 level before the Olympics was on the order of 100 micrograms per cubic meter. In New Jersey now, today, with the wind blowing, it's probably down around 5 micrograms per cubic meter. Often it's 10 to 12. And when you go on the parkway, well, I'll show you a picture of what happens. Anyways, this is the turnpike, not the parkway. And I want you to focus not just on the congestion at presumably one rush hour or another here, but at the truck lanes, at the trucks. Again, not that diesel is the only bad thing out there, but it's something we can kind of point at. We developed a protocol where we took healthy young students, this case Rutgers students, not Beijing University students, or excuse me, Peking University, and we put them in cars and drove them up and down the turnpike for about an hour and a half. And this is a picture of what we saw, with the blue being ultrafine particles, the green being PM 2.5. This is measuring inside the car now and leaving EOHSI and then up like this, and they stay up for the ride and they come back down. So this was our exposure, if you will, for an hour and a half. And we did that with and without wearing a filtering mask. And what you can see here for these different outcomes in exhaled breath condensate, we weren't taking blood from these subjects, we found at immediately after they went on the ride, that they had markers of inflammation in their breath condensate, nitrite and nitrate here, which are physiologically produced or pathophysiologically produced by the lung. They're not the nitrite and nitrate that you can actually find in the troposphere, but they increased by 65%, 55%, and 35% respectively. And then by 6 hours after, they were back down to their baseline. So for a much limited suite of outcomes, we showed that the same kind of thing we saw in Beijing at a more junior level, if you will, could be found in New Jersey. We also did some what we call controlled exposures. We have an exposure chamber at EOSHI, and upstairs in our attic is a diesel engine like you might take on a camping trip or to a football tailgate, and that runs through a muffler and a pipe and down into this room over here, which is the chamber, which person being monitored by a technician. This is one of our other technicians pretending to be a subject inside this stainless steel chamber, exercising to increase the respiratory rate and the dose of whatever particles or gases we're sharing. In this case, we're talking about fresh diesel exhaust. And just to quickly show you, I'm not going to go into that in detail, but whether we looked at our healthy subjects on the turnpike, healthy subjects in our controlled environment facility, or asthmatics in the diesel, asthmatics being exposed to diesel, in every case, those who immediately after the exposure The red bars, which indicated at post-exposure, are higher than the blue bars, indicating more, again, the same outcome of exhaled breath condensate nitrite as lung inflammation. We saw that, and it was significant. So what I'm trying to say to you is we want to prove whether or not air pollution causes heart and lung morbidity and mortality. In general, those of you who are public health students probably know Sir Austin Bradford Hill's elements, if you will, of thinking about causation. And there's a lot of things. Epidemiology, which is the association here, and perhaps the dose response, and replication of studies in different areas with different populations. Those are all really important elements of thinking about causation. The one that I have worked on through my career, done a little epidemiology, but it's this biological plausibility. It's showing that if we give you more pollution to breathe, your lungs get more inflamed, your blood gets more inflamed, you have more oxidative stress. And that helps to validate the epidemiology, which I showed you in that first slide from the EPA, on which there's thousands of studies. Biomarkers, there's probably only hundreds. So we took all this information to say, and we can kind of conclude now that all these different endpoints here, heart attacks, heart failure, stroke, chronically atherosclerosis, asthma exacerbation, COPD exacerbation, lung cancer, neonatal outcomes, death, and find all these other things, that more chronic things like diabetes, they've all been linked epidemiologically to increased levels of ambient air pollution. Well, we're going to leave ambient air pollution, maybe leave it, and talk about indoor air. Outdoor air pollution, it's associated with all those risks I just saw you. But guess what? We spend 70 to 90% of our time indoors, about 70% at home, about 90% of time in some indoor environment. And if you do the calculations on how fast you breathe and what the concentration of pollutants are, and you know that on a rough average, outdoor pollution levels, particle pollution levels, particles, transfer indoors at about a 50% discount. So if it's 20 micrograms per cubic meter outside, across the broad range of different housing types and apartments and whatnot, if it's 20 outside, it will average out to about 10 indoors. There's a lot of indoor sources too. Cooking is a real big one, especially if you don't have appropriate ventilation. Ozone comes indoors, but it gets greatly discounted, probably only comes indoors at about 20% of the outdoor numbers. And then there's biologic things inside, your skin flakes, which can react with ozone to make ozone chemistry outcomes. But anyways, we have all this epidemiology on outdoor air pollution. Nobody has ever done a study of clinical outcomes, heart attacks, respiratory failure, on indoor air pollution. Well, why not? Well, first, we don't measure air pollutants inside. But I just told you, you spend 90% of your time indoors. So, and the outdoor data that I showed you from those different cities before, that is measuring outdoor pollutants and the 10 microgram per cubic meter standardized change. That was based on measuring outdoor, just like it was for that heart failure study I showed you that we did at Rutgers. It's measuring pollution outdoors, but the people are really indoors. They're not outdoors. And so if you do the calculation, like I said, at least half of your particle load, because there are fewer outdoor particles inside, at least half comes from when you are inside. Big chunk of that is when you're asleep, but it comes from other sources. So even though there's no epidemiology of indoors, the outdoor epidemiology is really indoor epidemiology. At least that's what I would argue. There are things you can do about it. In China, they have built giant air pollution filters. that these are not widespread in China, but they've built them. In Delhi, which has much worse air pollution than China now, they've built similar devices to clean the ambient air. And there are some reports that they do lower the air in rather local areas. So, but that didn't really strike us as very practical, especially because the Clean Air Act has been successful and we do have relatively low levels of pollutants. But we decided to try, as many other people, not many, but at least 20, 30 other studies have done, portable air cleaners that you can go down and buy at Home Depot for a couple $100. Fancy ones might cost you $1,000. These things, you can put them down in a room, and if you can tolerate the noise, which isn't that bad, especially if you buy a more expensive one, they attempt to clean the air in your room, assuming it's the right size monitor for the right size room. What we found here, if you look at the captions that say Windows closed, Windows closed, Windows closed here for total, this is ultrafine particles, PNC is particle number count. This is black carbon and this is PM 2.5. With the windows closed, in every case, when the filter was running, but when the air cleaner was running, but there was no filter in it, that's the orange bar. The filter was in it when the blue bar. So you can see in every case, and this is a crossover study, in every case, the filter worked really well to lower particle levels by 50 to 80%. And there's, like I said, there's more than 30 studies out there that show the air cleaners do that. Nobody has ever shown that you could let people use their windows to presumably regulate temperature most of the time, and still find that the air cleaners work, because the recommendations are to keep your windows closed. The air conditioner is much more efficient, but it worked anyways. And that's going to be because we still found significantly higher levels of particles in the filtered condition. I'm sorry, in the unfiltered condition. So, and this is just showing, a while ago, somebody did a meta-analysis. It's never been published for various reasons, of 16 different studies, and showed not only did the filters reduce the particle levels indoors by 40 to 80%, but actually there's a suggestion across the studies that systolic blood pressure, peak expiratory flow, both got significantly better across all the studies. Although looking for a lot of those other biomarkers of endothelial function or inflammation, C-reactive protein, interleukin 6, they improved in some studies, but when you put them all together, the biomarker signal is messy. And so we can't really be 100% convinced that air cleaners really prevent. We know they seem to help biomarkers a little, inconsistently. We know they lower the pollutant level. They might help the biomarkers, but it's still a leap from only a few studies to know that they actually prevent heart attacks, or they prevent a second heart attack, or they prevent a stroke. So where we're left and where we sit right now is we think we can recommend to people. Well, we have choices to make. We could look at the literature and say, we know enough that reducing pollution is important and it's good, and people should just use these air purifiers, not electrostatic ones or ion generators, because they have issues with raising indoor ozone levels. We could say, don't just use them willy-nilly, but use them, keep your windows closed, and make sure you maintain them and you change the filter and do all that. We could recommend that we need to do more biomarker research, and we need to do bigger studies with more people in them, more standardized, because everybody who's done these studies uses a different collection of biomarkers. We do exhale breath condensate, somebody else does FeNO, somebody else does heart rate variability, and IL-6. And so there's not really a cohesiveness, if you will. Another option, and this is what a lot of people are advocating, is they need a really good clinical trial of air filters, where you take some high-risk people like those who've already had a first heart attack and therefore are at greater risk for a second, and you see if you can prevent that second heart attack by having them rigorously use air cleaners. The problem is, as the last bullet says, that the horse is out of the barn in the really polluted areas. If you can afford an air cleaner and you live in Beijing, you've already got one. So that's kind of where we're at now. A lot of people use these things. They find them desirable, especially in more polluted areas, but they aren't really proven to save lives. Now, there are other things you can use. You can use a face mask, which help, and they actually lower some biomarkers like blood pressure and improve heart rate variability, although they're kind of uncomfortable to walk around in all the time, especially a N95, better one. And of course, one thing that makes them more comfortable is if you put an exhalation valve in them, but that doesn't really protect other people from when you're breathing out. So you kind of need to use them without the valve, and that makes them a little harder to use. Sometimes we advise people to not exert themselves outdoors when there are higher levels of pollution, and that's behind the EPA's website called Air Now, which allows you to anticipate what the pollution levels for ozone and particulates are going to be like. When you're exercising, you can go up to a 5-fold increase of particles depositing in your lungs, which presumably puts you at greater risk of having an adverse outcome, either chronically or acutely. Exertion also causes oral breathing rather than nasal breathing, which reduces some of the filtering aspects of your upper respiratory tract. On the other hand, we know from controlled trials that exercise reduces the risk of cardiovascular events over the long term, chronically. Acutely, it actually raises it, but that's why we have graduated levels of exertion. So this is a validated treatment, if you will, to reduce cardiovascular risk. So telling people they can't exercise outdoors is a problem. So there's a bit of balancing involved here, and we're not sure. There are a number of risk assessments which try to modeling to combine these in these conflicting recommendations, and most of them seem to suggest exercise, except when it's really bad outside. But exercising indoors might be a good idea, and avoiding traffic-related air pollution, because we think combustion particles are worse for us than geologic particles. Avoiding traffic air pollution is good. Now, this is just to show you, kind of going back over the last few items. This is the seal of the United States Department of State. And I'm on a committee for the National Academy of Sciences, which is trying to advise the Department of State on how to protect our embassy personnel who are in really polluted cities. And one of the things about the personnel is they all have fancy air filters in every room of their home and also in the embassy. Because they're there with their families, their kids. Some of the kids are asthmatic. So they're very dedicated to having those air filters and to sealing their homes, not just closing windows, but putting tape or rubber aprons around the edges of their doors and repairing cracks in the walls so they don't let the nasty outdoor pollutants in. Well, that's interesting. And they do lower their indoor pollutant levels, air pollutant. But if you close everything off like that, you and all of your family who are little carbon dioxide factories who exhale 40,000 parts per million of carbon dioxide with every breath, concentration of 40,000 parts per million, that's producing a lot of CO2. We don't have measurements in their homes, but typically we like to see in a building no more than 1,000 parts per million of CO2, because otherwise it gets associated with stale air and what used to be called, or what is called, the sick building syndrome. But in many schools, we measure up to 2,000. In people's bedrooms at home, up to 2,500. Loading aircraft, boarding, up to 1,300 to 2,000. this may be, everybody thought this was not a problem. And then some literature started to accumulate doing controlled experiments in chambers where people were made to do difficult tasks, take really hard computerized decision-making exams, or in the case of the data in front of you, professional airline pilots asked to fly in a flight simulator at one point with 700 parts per million of CO2 in the orange bars here. At another time with, with 2,500 parts per million of CO2, so quite elevated over what we think of. And then some of them got this intermediate condition with 1,500. And what you can see here is that it should say down at the bottom, this was the easier flight tasks, more difficult and more difficult. What you can see here is a dose-response relationship between the passing rate of these already certified professional pilots and how much CO2 they were breathing for a couple of hours. Now, I should tell you that in US submarines, the levels are regulated at 5,000 parts per million. That's what they maintain it at. Same thing in the space station, 5,000. OSHA has an occupational limit of 5,000 for 8 hours. So what this is showing us is that pilots flew not quite as well when the CO2 went up. I don't know about you, but I'm planning on starting to fly again sometime in the near future. That's of concern. And finally, lastly and finally, you've all seen this picture designed by the CDC, presumably by health educators to try and get us to recognize our friendly virus. Some of you have probably seen this picture of what happens when we sneeze. This is the 6-foot stuff here. This is the bigger, heavier particles that settle down by about 6 feet. But you can see that this aerosol of tiny particles, at least, when I say tiny, they're at least less than PM10 to PM50. They're not as tiny as air pollution particles, at least not a lot of them. It's going out 8 meters. And if you prefer living color, you can see it here too. The big droplets are the greens. They're falling off in 3 feet, 6 feet, maybe 9 feet. And this stuff is just going to go out and just keep on giving. So, whoops. Let's get rid of that. And let me skip this one in the interest. And I'll just show you in terms of thinking about environmental justice issues, this is coronavirus cases for 10,000 people in the US. And we can see that our Black population and Latinos have a much higher rate of disease. The CDC has also reported in an EPUB article now that when somebody gets infected in your home and they go back to isolate in the home, that the average rate of transmission, looking at Wisconsin and Utah, a big study CDC did, was that 50% of households had a secondary infection, presumably related to the first person who was infected. And presumably, because these people were, in theory, all following CDC recommendations to avoid the big particles, which is wearing gloves, cleaning surfaces, staying out of the isolation room, we believe that it's most likely, which a lot of other people believe for other reasons, that the virus is being transmitted by those tiny aerosols, which will stay in the air for an hour, 2 hours longer. And that there's that aerosol transmission rather than just droplet transmission. And so we're actually investigating that by seeing if our air cleaners, which will not pick up the big droplets that don't get to them, but that our air cleaners actually can reduce the levels of virus in a home, and presumably, because we're not measuring this, can reduce infection rates, but we're not measuring infection rates. So we have a study where we're trying to go into the homes of people who've just been found to be positive and set up air monitoring equipment and air filters to see if active versus sham, filter in versus filter out, if we can lower the virus levels in the home. And this is 2 of our technicians, because our technicians do have to go into homes with infected people wearing powered air purifying respirators, they're not carrying the air filters with them now. Many collaborators, too many to thank, but in particular, Jim Zhang for being the PI on the Beijing study, and David Rich, who was so fun to collaborate with. So that ends my time.
This was fantastic.
Thank you very much.
This was great. If you have a question, we have a few minutes left. If you want to raise your hand at the bottom, I think there's a reaction. If you just want to raise your hand and you can unmute yourself and ask the question. So go ahead. Anyone have a question? This is really good. I like this very much. And if you want to stop sharing,
sure.
I guess that would be okay. I don't know if people will call back for a particular slide or so. But any questions?
I'll just echo Dr. Kittleson's comment. Howard, this was a great presentation. Very interesting. I won't ask a serious question, but I want to know, how late is Home Depot open this evening?
Well, if the answer I'll give you is I don't have an air filter at home.
Okay, thank you.
I did want to bring up something because you brought about the Beijing with the Olympics and all that stuff, because I know that was a real major concern, especially for the distance runners and those competitors outdoors. The fact that we have seen such a dramatic drop in travel, at least in the New York City area, has that, I guess I'm asking, how much of an impact has that had in improving the health of people? And I'm assuming that once we get out of this pandemic, that the travel will increase. We'll have more of that particulate pollution.
Well, it has been shown, at least anecdotal. Well, it's been shown that pollution levels did drop during various aspects of the lockdown. There's certainly a lot of anecdotal stories about people being able to see, whether here or in the Himalayas, being able to see mountains that they didn't know were around. I don't know of studies that have documented health outcome changes. There's a lot of conflicting stuff because with all the COVID, there are people who are staying away from emergency rooms where they might have gone there before during normal times because they're afraid of getting sick in the hospital.
Yeah.
So it's hard to do that epidemiology. My suspicion would be that people are doing it, but I don't know of them specifically.
Okay.
The other thing is, CDC, which they and the federal government have been urging us to conserve by having carpools to go to work or go to school. The official word from the CDC, I don't know what it is today, but months ago, was don't do carpools, drive yourself, don't take trains and public transport, because people were viewed as being a bigger danger than air pollution. So it's complicated.
Yeah. Well,
in Atlanta, Georgia, when they had the 1996 Olympics, there was a comparable drop in vehicular traffic.
Yeah.
Because the entire population was told, if you even try to drive downtown, you will be mired in gridlock. Well, actually, there was no gridlock. You could have painted the lines on the highway because there were no cars on the highway. And a study was done of respiratory outcomes. I don't have it in front of me. It was done by
Jennifer Peel.
Right. And wasn't Lauren Garretson, Bob Geller, and maybe Howard Frumkin on that paper?
I know Jerry Teague was involved.
Jerry Teague, right, from Emory. Anyway, that paper is out there, and I believe it did show a reduction. And at this time, there was no artifact of people being afraid to go to the ER necessarily. Right. So
it was, I think the big reduction they saw was ER visits for asthma exacerbations.
Right, exactly.
But there were some issues about confounding factors, and I forget what they were. Driving, I don't remember exactly.
Yeah, and in any big study like that, looking very globally at exposure, which obviously there's no exposure assessment, that's going to be the case. But,
well, You know, I think I used in my outline slide the term natural experiment. The one in Beijing wasn't really natural, but there are studies using a before and after design in Hong Kong when they switched to low sulfur fuel, in Ireland when they stopped coal burning back in the 90s, I think. So there are other examples where large populations changed, but I don't know of any that did it over weeks back and forth besides what the Beijing government did.
Well, this, Dr. Kippen, we really appreciate it. If you were in a physical location, we would present you with a plaque. We have a plaque for you, but we obviously can't give it to you physically, so we will be mailing that to you. I appreciate, we'll stick on for a few more minutes, but I just wanted, for those people that do have time commitments, if you could just check out the chat room. If you're an alum, there's a couple of links we'd like to have you consider to fill out. Dr. Shikarjian also provided some information about our sister programs, physical therapy and speech language, are also contributing some of the national public health initiatives. And so there's a link there to showcase some of the stuff that they're doing. And again, if you have some questions, feel free to stick around if it's okay, Dr. Kippen, for a few more minutes. For those that do have a time commitment, thank you very much. We have tomorrow's presentation is Dr. Howard, or Dr. Oscar Aline, I think that's how I'm pronouncing it right, who's from National Association for County and City Health Offices. And he'll begin at 3 o'clock as well. So you're welcome to stick around for a few minutes. Other than that, thank you very much for showing up. Dr. Kippen, this was really, I really enjoyed this. Thank you.
Excellent. Thanks so much.
Any other questions or thoughts? Feel free to unmute yourself.
Hi, Mark.
Yeah, who's
Hi,
that?
Michael.
Hi, Howard.
Okay, all right, there's
Great
Michael
talk. Thank you.
Shikarjian. Okay, yeah. And we had a pretty good turnout. We had at least